thank you very much to all our speakers. It's been amazing and incredibly informative, and lots of learning there for me, and I'm sure for everybody else as well. There have been lots of questions and messages coming through on Twitter, so thank you very much to everyone. And Cian, are you able to sort of take us through this and the questions?
Yeah, so I'm not surprised that Twitter is fizzing and spitting with questions for this session, and I'm going to direct the first one towards Vic. So what tips do the panel have for building relationships within departments quickly, and especially within the context of trainees rotating through a department pretty quickly?
Yeah, sure. I think what we found, unsurprisingly, was that culture often does get set at the top, but it certainly gets supported by those everyday conversations we were talking about. I don't know that you can set culture quickly. I think it is a process of everyday conversations. But one of the things that we did come out of our study, one of the interventions that the groups recognised, was the establishment of a code of conduct. And so we're very fortunate. We have some people who I think role model those culture of respects at the top end, our senior nurses and our consultants. But I think for us, this idea of a code of conduct probably was a good one. It would be something that would be reinforced by actions, but I think the words also do matter sometimes.
Yeah, of course. And Eve, just to take up on a point that you spoke about, how do you quantitatively and practically measure relational coordination? So for somebody that wants to set up a program for themselves and measure this, how would you do that?
You bet. If you're interested, I'd encourage you to check out the website that I think got tweeted while I spoke. The Relational Coordination Collaborative basically has a very well-validated survey across contexts that's pretty simple. It's 7 questions that people in different groups, each of these groups, answer. They answer questions about shared goals, shared knowledge, mutual respect, and communication across domains. So for example, the emergency department group, which in our study was made up of nurses and residents and consultants who are involved in trauma care, answered a series of questions about each of those other groups as well as about their own department. And it gives us some numbers at the end of the day. But we really found that the narratives added a lot to our work, and I'd encourage you to think about hearing people's stories as you're looking for that data about relational coordination too.
Then just to move back to you, Vic, trauma sims, we know they're a great idea, but in a resource and time-poor setting, how do you organise that?
Yeah, sure. Certainly at our institution, simulation is a big thing, and so we weren't too surprised when the staff mentioned those as some of the interventions they wanted to do. But I think it'd be worth noticing that a lot of them weren't very resource intensive, like the CT radiographers and our medical and nursing staff in ED about getting to the CT safe and fast is really literally the blow-up CT scanner. It's a short, sharp simulation where we just try and avoid all those tangled wires. Where do we put the ventilator this time? I don't know about you guys, but every time we go, it feels like we've never been before. And to sort of try and smooth that process down to really being a much more simplified process, something that we do consistently. So I hear the point, I mean, and we do only do those large-scale simulations once a month, but I think many of the interventions that came up weren't simulation as well. They were straightforward things like feedback processes to the paramedics, things that actually involved the group getting together and having conversations about how they solve their problems, not just in a simulated environment, but in the real world. So I'd say, yes, do sim, because I would say that, but it doesn't need to be complicated sim, but also I think engaging those groups, just saying how could we do better. People came up with a lot of things that were simpler, but I think even getting to those tasks means that we're building the relationships through the problem solving.
Sure, and I think one of the simplest things people ask for is, where can you get one of those inflatable CT scanners?
Well, Eve, in her rigorous anthropological way, looked it up on a website and got me one.
You too can have one.
And I suppose to throw a question to all three of you, how do you translate your simulated learnings into the real world when the stakes are higher and the stress levels are higher?
I had a bit of trouble hearing you there, Cian.
So how do you translate the lessons that you picked up in all of this project into the real world when your stakes are higher?
So I can answer that in two ways. One is we do have, as Jenny challenged us to, we do have some clinical outcomes that we're measuring along the way, some practical time-based targets like time to CT, time to the operating theatre, attendance at trauma calls, which I think does give you an idea if this lovely rainbows and unicorns relationships translates to hard outcomes. I think the other thing is that we do know, and people like Chris Hicks have been telling us this, that you do, play the way you train. I think one of the challenges with culture is it is easy to say and sometimes hard to see, but I think one of the things is to do authentic training that is actually about the kind of things that people find challenging. We mentioned trauma in this audience, but we do lots of simulations that are much more so-called boring, but I think really meaningful for people. So we're actually extending this research into the culture around our medical emergency teams on the ward, also other things for the operating theatre, and a range of simulations that might not quite hit the headlines at smack, but I think are possibly having a high yield in terms of the kind of outcomes for patients. Jenny might have a comment on that as well from a different note.
I think we could talk all day about every speaker, but I'm going to move on to Chris. Have you any practical tips to get junior staff to be honest with their feedback?
Well, I think it's something that you have to carry around with you. If you're a central member or a team leader, you have to make sure that you're setting a culture that gives people the permission to be honest, and that means being humble, asking questions with curiosity, showing genuine curiosity about what other people think, and then showing people that that feedback that they offer is actually influencing a change. You have to make people recognize that when they speak up and when they bring something to your attention honestly, that actually influences either you or your team or your system to do something differently. Because as most people can relate to, the fastest way to discourage honest discourse is to ask people to be honest and then not do anything about it. So you have to translate that into something actionable, I think.
And a theme that came up, Simon, a theme that came up from your speech, our talk, Simon, was, people, it's time-consuming, it's resource-heavy for traction, or how do you get traction on an organizational level for?
Okay, so there's a perception sometimes you think that this is going to take an enormous amount of time, that this is going to be a 4-hour session. The reality is, if you're doing this for trauma, I'm aiming to be out of the trauma room in 30 minutes max. So the observation period is very short. You need to set this up in advance so that people know it's going to happen, that you've agreement, you've got some form of contract that this is acceptable for us to happen. But the phone goes off. I'm doing some admin in the back office. I'm quite happy to pop into resus, observe for half an hour, and then meet up later on. Now, you do need some, I didn't mention it, but you do need some debriefing skills here. You do need some basic debriefing skills to go through that. And we're lucky that pretty much everybody I work with has got some form of debriefing course underneath them. And you're doing it between colleagues. So it's not a huge amount of time. This isn't a whole session where we're going to go peer observing. This is opportunistic. It's simple. It's available. And that's what I think the beauty of it is. Simplicity, availability, ease.
There was a question which is very applicable in an Australian setting as how do you suggest that solo isolated practitioners in a rural or remote setting might do this?
Okay, so we did think about that, and we think about it in the pre-hospital environment. It may not be possible in all occasions to do this. I mean, ideally you want to do this under direct observation. There are systems internationally where they'll do it with badge cams, they'll do it with helmet cams and things like that, but they're high technology, and again, that's not really where I'm at. I'm at the simplicity stage. There will always be periods of time, they'll be less frequent, when somebody might be available during handover periods, during crossover of shifts, where there might be the possibility to do this. But I absolutely appreciate that the smaller your units, the harder it is to do. I think that's a fair comment.
Moving on to Jenny, one of the themes that came out was how do you comply with the duty of candor while under the constant threat of criminal prosecution?
Sorry, is that you?
So how do you comply with the duty of candor when there's a constant threat of criminal prosecution?
Well, this is one of the big debates that's come up because, frankly, if you show real duty of candor, you could argue very clearly that you put yourself at much greater risk of prosecution. But actually what we hope now is, since David Sellou's successful appeal in the UK, there have been no further charges against any healthcare worker. We simply hope that the appetite for criminal prosecution will go down, and that people will begin to understand that actually that's not the right way to proceed, that we have to be open and honest with our patients, that we have to be able to learn from our errors, and we have to bring in this just culture everywhere. So that actually, because the criminal court, frankly, shouldn't be anywhere near these errors. We should be learning from them. We should still be accountable. We are not above the law, but it should be all about bringing in a just culture to improve patient safety, retain really good clinicians, and do good medicine.
And then a few people have wondered about written reflections. So after a situation, people would use a meaningful written reflection. There might be a precedent for these being used against them. How do you...
Can I give you some very practical advice? What you need to do with your reflections is you're not writing a narrative of that case, are you? If you've got someone, I don't know, if someone with poem syndrome in neurology, you are simply trying to extract the learning from that case. So your case, your reflection, you should not be able to recognize the basic medical elements of what was wrong with necessarily the diagnosis of the patient. And you want to make sure when you look back at it that it's not something that you could instantly relate to a particular patient. Focus on the learning points and the extraction of learning. That's the importance of reflection, because people rightly have been concerned. Dr. Bauer-Garber's e-portfolio wasn't introduced into the trial, but actually you saw her written reflections that were obtained in the canteen 5 days after Jack's death on that slide. Those did make their way into the trial indirectly. So please be careful, but focus on the extraction of the learning points, and you'll be fine.
I'm very sorry to say that we're going to have to wrap that up. It's been an amazing session, lots of great stuff. If I was to sum this up, I think really the learning that's coming out of this is that, to improve our performances, we don't have to make those big changes. Those simple changes will improve things, and those 1% gains. That actually building relationships across disciplines, across professions, the use of communication, key phrases to make people feel empowered, and about breaking down those silos. And that actually all of the talks highlight about the importance of feedback and reflection, and not just for our learning, but for improving patient care as well. So please join me to thank the panel. This has been brilliant.